Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues and PGs, we are discussing abdominal tuberculosis. Till now we had 3 lectures. In the first lecture, we discussed the historical background of abdominal tuberculosis. In the second lecture, we discussed the pathophysiology and diagnostic workup of abdominal tuberculosis. In the third and last lecture, we discussed the clinical presentations of abdominal tuberculosis, the 4 main types which abdominal tuberculosis may present with. And in today's 4th and final lecture, we shall discuss the treatment options of abdominal tuberculosis at present and what are the future perspective of this disease. So, topic for today's discussion is the treatment of abdominal tuberculosis. There are 3 main treatment options for abdominal tuberculosis: the medical therapies, the endoscopic therapies, and surgical therapies. We shall discuss these turn by turn. First, take the medical therapies. In fact, abdominal tuberculosis is essentially a medical disease and generally responsive to medical treatment alone. Early diagnosis can prevent unnecessary surgical intervention. Surgery is indicated in cases of non-resolving intestinal obstruction, perforation, and abscess or fistula formation. So these are the only 3 indications when we go for surgery. In remaining all patients, medical treatment is the treatment of choice, and early the diagnosis and early the starting of anti-tuberculosis treatment will prevent the surgical intervention. The treatment consists of 4 drugs: Rifampicin, Isoniazid, Ethambutol and Pyrazinamide for the initial 2 months, followed by 4 to 8 months therapy of Rifampicin and Isoniazid. There is confirmed high cure rate of more than 90% of cases after both 6 and 9 months of standard anti-tuberculosis therapy, provided it is not uninterrupted. Drug-induced liver injury during anti-TB treatment is the most common reason leading to discontinuation of therapy. When we complete the therapy, the outcome of the anti-tuberculosis treatment can be considered as complete response when there is resolution of symptoms, disappearance of AFB on smear or culture, and there is a disappearance of tuberculous granulomas, and disappearance or healing of active tuberculous lesions on relook colonoscopy or endoscopy. So when this happens, this is called complete response. Recurrence means endoscopic, colonoscopic, or radiographic documentation of recurrent lesions after a complete response had been achieved. So initially there will be response, but later on the disease recurs. There may be partial response. And by partial response, we mean resolution of symptoms and partial disappearance of tuberculous lesions at the end of the treatment. the response is not complete here. And in some cases, 5 to 10% of the cases, it may be no response. And it means persistence of symptoms, persistence of AFB on smear or culture, and persistence of tuberculous granulomas, and persistence of acute tuberculous lesions on colonoscopy, endoscopy at the end of the treatment. Coming to endoscopic therapy, like in this patients, I shown this picture in the third lecture, the endoscopic images, the gastric outlet obstruction in gastric tuberculosis, when it was dilated by the balloon. So, endoscopic balloon dilatation for the tuberculous stricture may be a treatment. Now, coming to the surgical options, the surgeries performed in the gastrointestinal TB are of three main types. These are of three main types. The first type is the surgery which is done to bypass the involved segment of bowel, as in case of enterostomy or an iliotransverse colostomy. These surgeries are usually complicated by blind loop syndrome, fistula formation, and recurrent disease in the remaining segment, and hence usually not performed routinely. So the first type of surgery in which bypass is done in the form of enterostomy or iliotransverse colostomy, but this is complicated by the blind loop syndrome, fistula formation, a recurrence of the disease, so these are not in fashion. The second type of surgeries are those involving the radical resection, like a right hemicolectomy, which are feasible with the advent of effective ATT drugs so as to eradicate the disease completely. However, these surgeries are also hindered by malnourished status of the most of the patients, which make them poor surgical candidates. Also, the lesions can be widely placed and radical resection may not be possible in all cases. The third type of surgery is usually conservative, like a stricturoplasty in those strictures which cause more than 50% luminal compromise. These kinds of conservative surgeries are usually preferred nowadays. These are the elective types of surgery. The emergency surgeries I have discussed with you under the section of the medical treatment. Surgery is performed in about 15% of the cases of abdominal tuberculosis. Half of these are performed as acute surgery, as mentioned before, including obstruction, abscess formation, perforation, or hemorrhage. The other half is a diagnostic procedure. The tuberculous bowel perforations are usually treated with resection of involved segments with primary anastomosis. So what do we know today? If I summarize that what we learned over these 4 days, abdominal TB can be of various forms like peritoneal tuberculosis, tuberculous lymphadenopathy, gastrointestinal tuberculosis, and visceral tuberculosis. Though gastrointestinal TB usually involves the ileocecal region, it can virtually affect any part of the GI tract. The symptoms of abdominal TB can be non-specific. Various imaging features and radiological signs are useful in making a diagnosis of abdominal TB. A high degree of clinical suspicion is required to make a diagnosis of TB in those areas which are not commonly involved. Various molecular and immunologic techniques are increasingly used for rapid diagnosis in suspected cases of abdominal TB, and gastrointestinal TB is generally managed with medical therapy with ATT, and surgeries are usually conservative and are done only if absolutely indicated. So, this was what we had in past, and what is the current status of abdominal tuberculosis, its pathophysiology, its diagnostic workup, its clinical presentations, and treatment of abdominal TB. What is the current status? Now, what is the future perspective? What the future can bring to us, and what should we expect? So we started our journey from the prehistory era, and we learned what was the status of TB in the prehistory era. Then in the history era, what was its status in the ancient era, then classical era, then middle era, Renaissance era, modern and current era. What beyond 2023? What are the new horizons? We need to progress in the development of new TB diagnostics, drugs, and vaccines. Since the introduction of the BCG vaccine in 1921, around more than 100 years ago, very few novel vaccine candidates have advanced into clinical efficacy trials. We need to develop new vaccines indeed. What about the tuberculosis drugs discovery? Progression and future interventions in the wake of emerging research is important. Drug discovery for tuberculosis has resuscitated after 4 decades of inactivity when the FDA approved bedaquiline and dilamanide. Multi-drug resistant tuberculosis and extensively drug-resistant tuberculosis challenge the public health system with limited drug options. The TB drug pipeline has adequate number of compounds that are under phase 1, 2, 3 clinical trials for their safety, efficacy, and tolerability on the TB patients. Repurposing FDA-approved drugs being used in other disease interventions can help in shortening the course of drug discovery, as the potential hits can jump directly to phase 2 clinical trials, and this is very important step. Effective strategies including nanotechnology, gene editing tools, host-directed bacterial killings should be utilized to better exploit the diverse chemical space for TB drug discovery. So, in the therapeutic area, there are many candidates now in the pipeline, and we can go on fast track by repurposing the FDA-approved drugs. And of course, we need effective strategies which will include nanotechnology, gene therapy, host-directed bacterial killing. This is in phase 1, different options are there. In phase 2, again, different options are there. In phase 3, and probably these will be leading to future intervention. These are the conventional approaches of drug development. And we need new approaches like host-directed therapies, drug repurposing, and nanoparticles as drug carriers. Tuberculosis is a chemotherapeutic triumph, but a persistent socio-economic stigma and burden. We know tuberculosis is now entirely curable in virtually all patients. Despite these effective chemotherapeutic and preventive agents, tuberculosis has receded to socioeconomically disadvantaged urban and rural areas where the incidence parallels that of developing countries. So both in developing countries and developed countries, it is still an issue. Conquest of the disease will require improved healthcare delivery to the indigent and dispossessed people. So, my dear colleagues and PGs, we are at the end of the abdominal tuberculosis series and ongoing saga. We started the saga from the prehistory and we discussed what are the achievements of different eras of the history. We looked into the past. We analyzed the present status of abdominal tuberculosis and we looked into the future. We just discussed what prospects can be there in the future, what are the new horizons to touch in the future. So, saga is a long story of achievement, rather series of achievements, and abdominal tuberculosis by no means is a saga. But this saga has a long way to run. So much is needed to be done in the future. Thank you very much for being with me over this series of 4 lectures. I hope I have been able to share with you my thoughts on the abdominal tuberculosis. What was the past? What is the current status? And what should we expect from the future? I stop here and thank you for being with me over these 4 lectures. Thank you very much.